Marnina Budni, and welcome everyone to our Cullen event for World Patient Safety Day. It is indeed my pleasure to introduce our visiting Nimmo professor for this event. Welcome to those joining us online, and just to let everyone know, because it's always difficult with clinical service delivery to get to everything, we appreciate that recording this will be of benefit to those unable to attend at the moment, and we will make it widely available on a link in the next few days. So please let people know if they want to watch it later. If you're a bit slow in getting to the room, please hurry, because there are Tim Tams and they won't last if people come to collect them, but that's your reward for coming in person. I'd like to acknowledge that we meet today on the lands of the Kaurna people, the traditional custodians of Kaurna Yerta. I pay my respects to their elders, past, present and emerging. I extend that respect to any Aboriginal and Torres Strait Islander peoples present today. It is my pleasure to welcome our speaker for today. Associate Professor Christine Jackman is our visiting Nimmo professor this year, and she's already given a number of talks, but there are a few more if you want to check the program coming up. And next week on Tuesday we'll be having a Nimmo Prize judging, so something not to be missed. She's going to talk to us about tribalism in healthcare, which is a fantastic thing at this stage in Cullen's development, I think, to consider about how we may not be doing the best for our patients by reverting to bad tribal behaviour, but I'll let her unpack that for us. Christine is a fellow of the Australasian College of Emergency Medicine and an active clinician working in ED. She's also the clinical dean of Epworth, and so she's got a credentialed background in both education and emergency medicine. She is passionate about making sure clinicians are the best they can be, and that's, I think, the best-selling thing that we could say about her for her Nimmo talks. So I'm going to let her take the microphone now and talk to us about tribalism in healthcare. Thanks, Christine.
Thanks so much, Jo, and thank you for having me here as part of my visit. I'd just like to acknowledge the people, the Wurundjeri people of the Kulin Nations, and that's the land that I live on and work on in Victoria, and to pay my respects to any peoples from those lands that are with us today. So I'm going to talk about tribalism in healthcare, and it may or may not be something that you've thought about or considered in your day-to-day work, or in how you think about healthcare. So let's start with a scenario, and this is a scenario that's not unfamiliar to me. It's 10 o'clock at night, it's a busy emergency department. We've got ambulance ramping outside, there's a whole lot of pressure to get patients moved through the department. I'm sure you're all very familiar with that scenario. Your ED registrar is trying to get a complex patient admitted. They've been making calls for the last 30 minutes or so to general medicine, to oncology, to respiratory, not having any success, and they're due to finish their shift at 10. They've just done 5 shifts, evening shifts in a row, they're exhausted. And they come to the consultant in tears. Just think, can you imagine this situation may have happened? What's the consultant's response going to be? And what's going to determine that consultant's response? So I've been in this situation, but let's say this consultant, knows this registrar quite well. They've been working with them for quite a while, and they really like this registrar. They go, this is a really good person that we really want to have in our ED, and we really would like them to come back and work as a consultant with us, because they're pretty fantastic. They've got great clinical skills. They work well as a team. They're really great. They're part of our tribe. They're part of our tribe, and I want to look after our tribe. I want to do the best by that tribe. So one of the possible responses here is that consultant could ring up any of those registrars listed above, whichever was deemed the most appropriate for this patient, and say, you need to take this patient. I'm going to send them, I'm going to admit them under you, you're going to take this patient. Well, we might think, well, yeah, that's really good for the patient, it's good for the registrar. Is it good for the other registrar that we've just done that to? Maybe not. Maybe think through that. What could they be feeling, having a consultant say, you're taking this patient? The consultant could even take it a bit further and go, there, you know, I've supported you, we've got the job done, we've got another patient out of emergency, off we go, we can get another patient in, we've let the ambulance, another ambulance go and pick up another critically ill patient. That's really an example of tribalism. It's actually saying, I'm actually fighting against you to get a patient admitted, and I'm actually going to use my authority over you to get that patient admitted. But I really thought about what's going on with you, with those teams. I'm going to come back to this scenario a little bit later after I've had to talk a little bit more. So what do we mean when we mean a tribe? So it's often referred to as, you know, anywhere from 20 to 150 people. Once you get more than that, then your tribes to break into sub-tribes. And that tends to be what happens. You get a break in the culture and you actually get sub-tribes. And tribes all share a common culture. And you might actually think in your non-working life, you might have some tribes you hang out with. It might be the local footy club, it might be the local hockey club, it might be, you might do theatre or something like that. And you might have a really nice tribe that you hang out with and you have a lot of common interests and common culture. But these tribes also occur in the workplace. And they're very, very strong and they very much influence what happens in the workplace. So, how do we define tribalism? So this is one definition, that it's the loyalties that people feel towards particular social groups and the way those loyalties affect their behaviour and their attitudes towards others. Let's go back to my ED registrar. What if I felt very differently about that registrar? What if I didn't feel a very strong sense of tribalism or a sense of connection with my fellow ED colleagues? May have behaved very differently. Just have a read of this, look at this cartoon, because I think it actually tells you a lot about tribalism. So if you look at this cartoon, they're exactly the same things on either side of this water. You see, it's exactly the same thing. It's the same type of leader. It's the same religion. It's the same, people on either side of the river. But their tribalism makes them think that they're different. Another definition of tribalism is perhaps not such a positive definition. So it's the loyalty to a tribe or other group or other social group, especially when combined with strong negative feelings for people outside the group. So that's perhaps a less positive version of tribalism and probably much more what people are using now when they refer to tribalism. So it is actually your people come together but with a negative against another group. So let's again go back to our emergency department scenario. So you can imagine, I'm not saying this is the case, but you could imagine that within that ED group that they're going, oh, those bloody inpatient registrars. Use the language, but that's probably what they're saying. They won't accept the patient, they make it so hard, all they do is push back. You know, are they doing any work at all? Can you imagine that? Yeah, it could happen. I'm saying this because I'm an ED doctor, so I feel I can say that about my own. All right, so the one key question I'm going to ask you today is how can we work as one tribe to improve patient outcomes? Because we all want to do the best for our patients, but do we always work together to get that outcome? So I want you to think about your tribe. Who would you think is your tribe? And you might actually have a couple of tribes. So have a think about that. Who's your tribe? Who do you think is the people that you have the shared culture? And I'll just give you some ideas. So I have a few tribes. So I call my ED tribe, and we're a pretty tight-knit group down in ED. It's always down in ED, isn't it? You always feel like you're in the basement or the dungeon, but just because it's easiest to have EDs on the bottom floor, isn't it? But I've got my education tribe. So I have a connection with a whole lot of educators, for example, where we have a lot of common ways of thinking about things. And we do some really good work. Like we do some really good work in ED. We do some amazing things for our patients. And at my group of educators, we do some amazing things for our learners. So think about what your tribe is. Now I want you to think, what are some of the positives of your tribe? I'm going to ask some of the people in the audience, what are some of the positive things about your tribe? Maybe back there in the green jacket. Can you think of a positive about your tribe? Maybe tell us what you...
The positive, shared purpose.
Shared purpose. Okay, so you feel like you have a common goal, that you're working towards something together. Yeah. How about right at the back there? Supportive. Okay. So a shared purpose, a support network for you. So do you, I might put words in your mouth here, do you feel that being part of that tribe, you've got people you could go to if you need some assistance or help or you have a question, that sort of thing?
Yes, and without criticism.
Without judgment. That's really important. Okay, so you feel that you've got support without judgment. Okay. Are there any negatives to your tribe? Like, have you got some thoughts about your tribe? Anything negative about your tribe?
Pretty self-critical.
Self-critical, okay. Okay, so they're pretty hard on themselves.
Yeah.
Yep, okay. Sounds like a medical crowd. Yep. Right. How about down here? If you can think of your tribe, anything negative about your tribe?
You get focused and you see a different way.
So maybe lose sight of the big picture? Yeah, so maybe you're so focused that you can't see what everyone else is doing and how it might interact with all your other tribes. Okay. So tribes are very powerful social units, but the progression of a tribe and how it progresses and functions is very much dependent on the quality of connections between its members. I'm hearing some really positive connections here. So if one of the things that's really positive about your tribe is that you feel very comfortable and very supported and very willing to ask for help, that sounds like a nice tribe to be in. I wouldn't mind that tribe, that sounds pretty good. But not all tribes are like that. So let's think a little bit further. So there's a researcher and a man by the name of David Logan. He works with the University of Southern California and he works in the business space. And he's actually described different types of tribalism. So this is a way, they've gone out, he's used a group of researchers and they've gone out into multiple different organisations and they've looked at how different groups within the organisations work, but also different groups in society and how they've worked. And he's come up with these 5 stages of tribalism. And I think it's really helpful to sort of put some language around where your tribe might be at, because tribes move between stages, but some tribes get stuck in a stage. And that's actually really useful to describe that stage to work out how to get out of that stage. So stage 1 of tribalism, he describes it as life sucks. So the people in this tribe, life sucks, it's us against the rest of the world, there's nothing good about this world, we're angry, we're destructive, we cause chaos. And this is the sort of tribe that's functioning at the level of a gang. You often see this sort of tribe in prisons where they, it's every man for himself and the world sucks, so I don't care how much harm I cause to anyone else. Okay, and I'm really hoping none of your tribes are at this stage, because we probably need to get some urgent help to get at that stage. Okay. But then we've got stage 2 of tribalism, and anyone who's sort of watched The Office, that's probably where they sit. It's a great show, really, but it is really a satire, isn't it, on stage 2 of tribalism. And that's where people go, well, my life kind of sucks. My life sucks. I've got a little bit of hope, I've got a little bit of hope, but I don't feel valued for what I do. It's always the boss's fault. It's always the boss's fault. So if the boss just did this, things would be better. And they're often very passively antagonistic. So it's like, oh, well, why are we doing this? We've tried this before. It's not going to work. It's a bit of a can't-do attitude, not a can-do attitude. You may hear some familiar things here. Does this sound like a tribe that's very burnt out? That's like, oh, we keep trying to change things, nothing changes, I don't have any power to do anything, I can't make the change myself. It's a very much where people sit when they're very burnt out. They really feel very disempowered and they feel, a bit hopeless. They've got a little bit of hope, like there's a glimmer that something will be better, but they're the ones that you're going to come across when you try and institute change. That's where you have a lot of that passive antagonism. Stage 3, we're doing a little bit better here. Doing a bit better in stage 3. And this is where the individual's thinking, well, I'm pretty good. I'm pretty good. But you're not. I'm a bit better than you are. Okay. So that's great for the function of that tribe, that they think they're pretty good. But they are very busy. These people are very busy. They don't really have time to help anyone else, and they feel that they never have enough support. So I'm doing all this, but no one's supporting me. But they're pretty good. Like, these people really get things done, right? They get things done, but they feel unsupported, and they don't really feel that they can bring anyone else along with them. They don't feel they have time to help anyone else. I reckon that's where a lot of healthcare workers are. I've only been at the Royal Adelaide since Monday, so I can't make a comment. But I certainly know in my work environment, there's probably a lot of people in this situation. They're all trying really, really hard, and they're all trying to achieve things. As they are in stage 2, they are still trying really hard to achieve things, but they're a little bit of lone warriors. They're out there doing their own work, but they're struggling. And they do at that stage have a tendency to say, I'm doing all this, but you're not doing anything. So it's the joke, the 3 consultants get into a lift, okay? The first consultant says to the other 2, I just wanted to let you know I'm really, really excited. I just got my research published in the medical journal of everything, absolutely amazing. All right. So, it's been a lifelong dream to publish in this journal. It's fantastic. And the other person in the lift says, that's great. That's fantastic. But I've just done my 50th procedure that no one else in South Australia can possibly do, with incredibly good outcomes, and I'm now, the world leader on this procedure. Okay. And then consultant 3 says, that's awesome, the publication, that's fantastic, and the procedure, that's fantastic, but all 15 of my PhD students all just got their PhD conferred, and they're all publishing in the Journal of absolutely everything amazing in medicine. All right, so they're all trying to achieve something, but they all want to be that bit better than the person before them. Then we get to a different stage, stage 4, and probably the first thing you can see here is I've actually gone from I to we. Okay, so we're great. So this is where your team really unites around a core set of values. And the groups of people within the tribe are actually working towards, they're working together with shared projects and common values, and they're really trying to achieve something. So you're now saying, my tribe, it's not me and my tribe that's great. It's we're great, all right? Kind of a nice place to be. It's a really nice place to be. Is it perfect? No. It's a pretty nice place to be. And then the 5th stage is, life is great, okay? These are people that just don't see any limitations. Their communication within their tribe is all about limitless potential. It's like, we can achieve anything. The only thing that bounds what they achieve is their own imagination and their group commitment. And these are the sort of groups that change the world. These are sort of groups that create things and make things and actually really, grow and change our world. So this is a really difficult stage to get to, and it requires amazing leadership and amazing people in that group to really get to that stage and to understand where they're at. And you need a lot of enabling to get into that stage. So how do you progress? Through these stages? So as I said, I hope no one's at stage 1 with their tribe. I suspect we've got a few stage 2s, and you're not always going to be at stage 2. You might fluctuate between stage 2, 3 and 4, depending on what else is happening in your environment. But to progress your tribe, you actually have to feel safe enough to value collaboration over competition. So it's not about I being better than you, it's about us being good together. And that's really challenging because, particularly in the medical profession, where we're trained right from day one to be better than everyone else. We've got to get the top marks at school to get into medicine. If you do an undergraduate degree, you've got to get your distinction, high distinction average to get into medicine. If you get straight into medicine, then you're all trying to compete with each other to get into training positions. You're always trained as doctors to try and be better than someone else so you can get the thing that you want. And then we work in an organisation which is all about teams. It's all about teams, and it's not the culture that you've been brought up with as a doctor. I think it's a bit better in some of our allied health colleagues. I really do. I think they do work a lot more collaboratively. But I suspect there's still some of that that's happening. You know, we're always fighting for jobs, for promotions, for the things that we want. So when people feel safe, our tribal interactions really begin to focus on the collective goals and uniting around shared values. So that safety is really important. But according to David Logan's work, he thinks there's only about 22% of tribes at any point in time that are actually at stage 4. And only about 2% ever get to stage 5. Okay, so it actually is much harder than it seems when I just sort of talk it through to you. So it is a challenge to move stages. So it's important that the tribe realises there's something greater than their individual competency, and then they can start to work towards that united goal. So we all want to be the best clinician we can be, but we can be the best clinician we can be if we work in a team that enables us to be the best clinician we can be. And then you get a shift in your tribe. So this is particularly moving from that stage 3 to 4. You get a shift in your tribe where you go from very highly motivated, but a bit more individually focused team to a collaborative team. So how do you make that move? How do you get there? So it's a lot about building relationships. So really building relationships, being human in your workplace. To think about, particularly when you're interacting with other tribes, how do you be really human and really show that you value another tribe and that you're not competing with them, that you're all working together. So I'll give you some really simple examples. Okay, you're starting your emergency shift. Again, I'll come back to what I'm familiar with. You're starting your emergency shift. You know there's going to be a radiology registrar on for the shift. You just pop around, say hello, don't need anything from you at the moment. Just letting you know I'm the senior on the shift today, and just wanted to let you know who I am, and yeah, just say I'm looking forward to working with you tonight. You're in on a ward round. Let's say it's the medical team who's doing a ward round. You bring your nursing staff that's looking after that patient on the ward round with you, and actually take them to a leadership role in that round because they know their patient better than anyone else. They've been looking after that patient. So be really human in those interactions and actually acknowledge people not when you need something, but outside that time. So those really simple positive things are really important. So if you think, let's say you discharge someone to rehab and then they came back to see you in outpatients and they were doing brilliantly, like the whole process of rehab had worked really well, actually go and tell the people at rehab. Tell them that, this was a great outcome and you're really impressed by what they've achieved. Not, I need something from you. Tell them when they don't, you don't want anything else from them. It's really important. Look for opportunities to build your relationships across tribes, and I'll just come back to that in a second. And actually try and connect your tribes. Say, okay, you've done a bit of research in this aspect of whatever. You're actually doing something a little bit similar over here. Okay, maybe you guys should get together and think about how you could do a collaborative project. So bring people together is really important about breaking down those tribal barriers. So there's different ways we can bring our tribes together. So education is really, really powerful. And this is actually, I guess, one step of that, is actually doing education between different tribes and not always having all your education in silos. And it's really easy to go, well, we're the cardiology unit, we'll have cardiology teaching, or we're the respiratory unit, we'll have respiratory teaching. But actually think about, well, what are the things that you're all dealing with that could really benefit from common education, and bring your tribes together, bring your minds together, and actually use the resource of everyone. So, it's a great opportunity to brainstorm. One of the things that I think it's at Stanford University that they do is they put healthcare professional trainees with their business school people, and they set them up. They get these people to come up with a problem that they see, and they actually all sit there and brainstorm an approach, call it design thinking. In the perfect world, how could we achieve the outcome we want to achieve in the perfect world? And then they start to work backwards and go, well, what are our resources and how could we manage it in our current environment? So you get people that think about a problem in a different way together, you actually get a better solution because you've actually got people thinking about it from all different ways. And it's really, really powerful. I'll just give you an example, and it's a crisis situation, but it's just where someone who is new to the environment, who's just in a position to stand back and observe, could actually change an outcome. So this was one of my colleagues when I had a cardiac arrest. The resus team was doing what the resus team does, and they stick the pads on, they're hooking up the defib, doing all that. And then there was a student nurse who'd literally been on first clinical placement, been there for about 2 days, so completely new to the clinical environment, who just casually sort of put their hand up and just said, "You meant to put the pads over the pacemaker?" And apparently the whole team just went, right, ripped off the pads, repositioned it, and, it's probably a better outcome for that patient that they didn't have their pacemakers out. So people from different tribes can actually really help, and doing education together and learning about what everyone else is learning about is really helpful to get on the same page. Research is another really good way to bring your tribes together. To think about how you collaborate with research. So in my work environment at the Epworth, I remember recently we had a grand round where we actually had a patient who'd had a significant cardiac issue who had then gone through cardiac rehab, actually come and tell his personal experience of that. And after that, it was really fantastic, actually. It was really enlightening about how the patient shared his journey. And what he experienced and why he really appreciated the rehab process and what the rehab process had actually, how that had supported him. And that was actually really, really useful for our clinicians to hear that story because, they'd sort of gone, yeah, cardiac rehab, tick, it was just one of those tick box things that they'd gone through. But actually to realise what the support was for that patient was really, really important. So he's a different tribe, isn't he? He's the patient tribe. He's a different tribe, but actually learning together was really, really important. It was a really, really powerful learning experience. So I want you to think about the impact your tribe has. So let's go back to your tribe. What's the impact? We talked about some of the positive and negatives about your tribe. What impact do you have as a tribe in this work environment? What does your tribe do? What's the impact of your tribe?
Well, I guess I'm predominantly also community impact teams, so I guess I'm sort of like gateway to the information forward side of things, sort of what you're saying earlier about answering questions.
Yep. So what do you think your impact is, though? So what do you think is that your team achieves? What does your tribe achieve?
Well, that hopefully we can be friendly and welcoming.
Yeah. So let's get it right down to the fundamental level. You're actually caring for patients. Yeah. And I'd hope, and I'm pretty sure this is what your goal is actually to give them the best experience and the best care that you can. So that's the impact that you're really looking at. But different tribes will have slightly different impact in that care pathway. So your impact may be in the decision making in that pathway. Someone else's tribe's impact may be in the carrying out of that decision making. Yeah. And so recognising each tribe's impact in that patient care journey is really, really important, isn't it? To actually know, not just to value what they do, but to understand what your different providers can do. And I'm sure everyone's had that scenario where, the doctors make the decisions, but we do all the work. Anyone heard that? But everyone contributes, don't they, to that patient journey? Everyone's contributing to that patient journey. So the other thing with our tribes is that leadership is really, really important in our tribes, that our tribal leaders really influence the culture of their team and their tribe. And our organisations are really a sum of our tribes. Some of our tribes propel the organisation forward, propel them towards really good outcomes. Some tribes can create friction. And I'm sure, and they don't create friction all the time. Like at times they'll create friction. And I'm sure you could probably think of a tribe that you've had to work with where you've sensed some, they'd only just, anyone had those tribes? If they just, do this, we could move forward. If they just get with the program, we could move forward on this. So our tribe, that combination of where our tribes are at is so important in determining our whole organisation's culture. So how do we get our tribes working well? So this is where the leadership is really important, that your leaders really need to do check-ins and really do that regular service and oil change. You often talk about the medical as being, the medical assessment, it's the service and oil change, you check your HbA1c, you check your cholesterol, your blood pressure, it's a bit of a service and oil change. But you need to do that with your groups and you need to know where they're at as leaders. Because if you don't understand where your group is at, you're not going to get a tribe or a group or a team in your organisation from stage 2 to stage 5 in one go. So you've got to understand where they're at because you've got to take them one step at a time to actually get them to that collaborative stage. If they're at stage 2, they don't feel safe. They don't feel safe. So getting them to that really collaborative stage 4 is going to be really difficult until they feel safe, until they feel valued, until they feel appreciated. So when you do those service and oil changes, you've got to work out what is working, what's working well, because you want to do what's working well. You want to keep doing it, don't you? You want to keep what's working well. You've got to work out what's not working well. But it's more than that. It's more than saying, well, this isn't working, this isn't working. It is, what can we do to make it work well? And get your team, your tribe, to actually all input into what that is. Because everyone's going to have a different perspective. Given that you're a tribe or a team, you've probably got a very similar goal. You might have a very similar goal, but you might realise that some of the people in your team actually don't have the same goal. They might be off on their own, with their own purpose and their own goal. So actually bringing people back into the same goal is really important. So, as I've alluded to before, the more tribes you have in your organisation that are functioning at stages 4 or 5, the more you're going to get done, but you're also going to have a very happy, much happier workplace and a much more supportive workplace. And the performance of the organisation isn't determined by a leader. And so people say, well, it's the CEO's fault, it's the executive's fault. I'm sure everyone's had that temptation to say that, well, if the executive just did this, if they just listened, if they just did this. It's not. It's actually, the performance is really set by the aggregate of all the leaders of all the tribes. It's not just one tribe. And remember, the leadership is actually just another tribe. Your executive is just another tribe. So they've got shared goals, they've got shared values, but they might not be the same as your other tribes. But understanding the other tribe, getting your leaders to understand what your goals and aspirations and values are is really, really important so that they can actually enable those tribes to do what they need to do. So good health outcomes can't be achieved by this us versus them mentality. It can't be, oh, well, if ED would be all better if the inpatient registrars just accepted the patient. So let's just think about those inpatient registrars. We had, general medicine, we had thoracic medicine, we had oncology. So let's think about what was happening with them that day. So our oncology registrar had just certified a patient that they'd been caring for the last 3 months and had actually really, really liked this patient and had developed a really strong relationship with this patient and is absolutely devastated. They've also just sent another young leukemic patient, we'll say, to ICU with febrile neutropenia, and it's touch and go. And they've just been talking to the family members of that patient. And they're feeling pretty fragile. It's been a really tough, couple of hours. The general med registrars had a whole day where, and I'm sure every general medicine registrar's experienced that every unit wanted to admit to general med and They feel completely overwhelmed. Their unit's just blowing out in numbers, and they really don't feel they've got the capacity to care for the patients they have, let alone an additional patient. And that thoracic medicine registrar has been told by their superior, we're admitting too many patients to thoracic medicine, you've got to say no. They've been putting under a different pressure. So thinking about those people, if you don't understand where those tribes are coming from, it's very difficult to work well together. And part of that being human is actually exploring why. Because if that person says, look, I've just had a terrible time, just lost a patient, I just really don't have the capacity to take on a new patient at the moment, you're probably not going to push, are you? And having someone come in and say, you're taking the patient, you've got no choice, is that good for the patient? Is that good for patient safety? It needs to be a collaborative decision. And it might be that, you work out a medium ground somewhere. So, the oncology reg does a bit of the legwork, they come in under medicine, and thoracic medicine comes and sees the patient really early, whatever it is. It depends how complex this patient is and what happens. So you actually get all the tribes working together, and then it's the patient that benefits. So tribes need to come together to collaborate, to create an us versus excellent patient care mentality. So it's not us versus them, it's us versus excellent patient outcomes. So that is our goal. And I'll just let you read that cartoon because I think it says it all. Make sense? So I just have this feeling if our two departments could just collaborate, we could come up with something that's truly amazing. We've got the fish department and we've got the chips department. So thank you. Thank you for listening. And I'd really encourage any comments, discussions or thoughts, because that's actually probably the most powerful part of this talk, is actually the things that the ideas and thoughts that come to your mind hearing this conversation.
Thanks, Christine. And I've got the chat open so that if you want to raise questions on the chat, you can, or if you'd like to turn your camera on, you can speak. We can hear you quite clearly if you want to turn your camera and your microphone on. But I just wanted to ask you a question. David Logan says you can't just talk like the stage above and the tribe will just automatically get up. And I find that so dispiriting because I just want to say, but come on guys, life's great, come along. So maybe I'm one of them stage 3 nutcases that just thinks I can drag everyone along with me. And I'm thinking about it really, since you introduced me to David Logan's tribes. I think lots of our tribes might be in about 3. I don't know, do you think, Catherine? She's hoping.
We've got some twos.
All right, so she thinks I'm too. And so if we can't do that, what you're saying is we really have to do something differently in that level 3 tribe that's got a lot of good potential to change things. And David said it's about listening. So can you expand on that? Like how are we meant to do this?
So I guess one of the reasons people particularly get stuck in stage 2 is they feel that they're not listened to and they're not heard. So there's been a few educational strategies, for example, to try and get people to move into more that stage 3 and 4 thinking. So one of them is translational simulation. So this is looking at how you develop, say for example, you're introducing a new service or a new process or a new care thing. So at Epworth, for example, they introduced a new apheresis service. And so the educators there, they were trying to work out, the education program, how do we, do the education around the new machine, our emergency procedures, and they had this huge education program designed. And then they sort of went to our sim team who do a lot of work in the simulation space and said, oh, what do you think of that? And they said, well, part of this education is ALS, right? But they all do ALS anyway. That's part of the inpatient training. Clinician training. But it's like, have you explored with each of your clinicians that are going to be involved in this process whether this that you're going to try and educate them about is actually going to work? So they actually ended up running what we call a visually enhanced simulation. So they just used, laminated pictures of different things, and they got each member, all the members of the team that were going to be involved in this system to come down and actually think about, okay, this is where the patient's going to start. This is how they're going to progress through this service. This is the machine. And they actually worked out some really nifty things about the machine and the alarms. I don't actually understand the machine, so I can't actually give you the detail on that. But each member of the team was actually going, actually, that probably wouldn't work. We might need to think about this. And they all contributed to design this process about how they're going to care for this patient. So it was all their input that was then collated to design their final process. So rather than educating them about the process, they actually created the process with some really good facilitation and guidance. And it's just started running, so I don't know what the outcome is. But the sense in that room was this group were like, we're all a bit scared and terrified of this new service. They'd all been sort of haematology nurses and worked in haematology. They do a lot of haematology work, but they hadn't done this part of it. And so that made them feel like they were really empowered to contribute to the decision making. But it actually was probably a better decision.
Yeah.
The decisions are actually better because it was very practical what they achieved.
Drawing on everyone's knowledge.
And it was drawing on everyone. And so every member of the team felt valued in what they were saying. So that feeling heard is really important. And in any situation, like when do you feel your worst? It's if you're like banging your head against a wall and no one's hearing you. That's when you feel your worst, don't you? Like you know what you want to say, you won't know what you want people to hear, but they can't hear it. So that's where that service and all change is really important. Is actually getting people to sit down and actually basically debriefing how your team's going. And it has to be done in a very safe and positive way, because otherwise some of those stage 2 people might start laying into some of those stage 3 people, mightn't they? Well, you just get everything you want, It has to be, that's where your leadership's really important, is to let those people be heard.
So I think you've answered sort of one of my other questions is, are there people at different stages within a tribe? Is that what happens?
Well, they tend to make their own tribe, so they sort of drop out of the culture. So, so if you get a lot of stage 3 people, they start to come together as they start to form their own tribe, because the stage 2 people, you're now not sharing the same values. So if you've got people that are moving out of that tribe into a different tribe because you're sharing different values, that's making those stage 2 people feel even worse.
Gotcha.
Catherine. Yeah, thanks, Jo. Catherine Zeeks, I'm the Executive Director of Clinical Governance. As you would know, because I know of your background and know of you, the clinical specialty tribes, particularly, I think, I'm not calling out ED and inpatient, but how do what are tools and tricks that maybe have worked for you about bringing together those clinical specialty trials?
So again, translational simulation is another one. So one of the things we haven't actually done it yet, but we're going to trial it, is just working through our process of getting patients from, with a STEMI to the cath lab. Okay, so it's a pretty well recognised thing. We know that there is extremely good evidence to, decrease the door to needle time will improve outcomes. There's been little glitches along the way, and we need the ED guys to work with the cath lab guys. And when we sort of did some preliminary work on this, the cath lab guys were sort of saying, well, the ED guys give us this handover, but they don't tell us the things we really need to know. Like it's a simple thing, isn't it? So the ED guys think they're telling them everything they need to know, but the cath lab guys are going, I say guys as a generic unisex term, they're sort of saying, but we don't know this and we don't know that. And the ED guys haven't even thought of what those things are, because, they've done their bit, they've delivered them to the cath lab. And so that little transition actually slows things down, because they're asking questions and, it's not coming out straight away. There's, front of house issues. What is our process when someone comes in with chest pain and our cubicles are full? Because that never happens. Right, so what is our process there? And that involves, the nurse in charge, the doctor in charge, but also it means that actually feeds into other processes. Does the nurse in charge and the doctor in charge actually have a full sense of what's going on in the department at any point in time? Because if you've got a big department, that's actually really hard, because a lot of big departments are divided into separate departments. You know, like there's different parts of the big department. So those big departments are a nightmare.
Just a comment, one of the other areas that you haven't researched in education where you have multidisciplinary collaboration for quality improvement as well.
Oh, absolutely.
If you're going to try and do some quality improvement, but you don't include all the disciplines, like adaptation, or you did quality improvement training to a specific discipline as well. And again, I think you can encourage that tribalism as well. Another question is, do you think if you move between tribes, if you have people moving in sort of ED and the general areas as an example, so moving between, do you think there's a better understanding and that helps move the tribes a little bit?
Oh, absolutely. I think that probably
Not up to that.
the most powerful thing I did in my training. So yes, I trained as an emergency physician, but as part of that, I did a year of surgery and I did a year of medicine. I did anaesthetics, I did ICU, and it gave me this really different perspective. A really different perspective. I mean, we're required to do, you know, stuff outside of ED as part of our training. Having said that, the training program has changed a little bit, and there is less outside of ED that you need to do. But geez, did it change the way that I saw the way the health system worked. And I actually started in the surgical year, so, and then went to emergency. So it was actually very eye-opening seeing things from the other side. And I think you can't undervalue that. And that's why, you know, the quality improvement processes, there are so many things that are common to every path, aren't there, in every discipline. So they should be working together. I mean, it might, if you're talking about, I don't know, some whiz-bang fancy orthopaedic piece of equipment and the quality around that, well, yes, it is going to be very, you know, focal and localised, and that's probably a relatively easy project to run. It's these things about, you know, how we're communicating, how we're discussing goals of care, for example, with patients, who's doing that. That's needing to happen with every service, isn't it? So how do we develop the quality around that so that we're actually achieving goals that our patient, you know, that you've discussed and worked through with your patient, and are they joint goals? Because your patient might have different goals to what you do. Yeah.
I think, Steph, that things like the safety and quality unit, who have that vision throughout multiple areas of the organisation, are probably really important in terms of that connection between tribes, aren't they? I feel like in education, where we're looking after training medical officers in multiple programs, we get a really good view across multiple programs as well. And I think that if we're able to better share that knowledge, that could surely feed into this collaboration between tribes.
Yeah, I think quality and safety is an awesome, and infection control is another group. Yeah, that they're really important groups to bring tribes together. So you can actually look at things from different perspectives. If you look at, for example, I don't know, infection rates in something, you could say, well, what's happening in ICU, what's happening in the wards, what's happening in theatre, you know, and actually look at all those different groups and see if there's different practices, because they do sneak in. Tribes start to develop their own way. Yeah, it's always the classic. I mean, I used to work with Alfred Health, and there was people would say, you'd say, why do you do it like that? And they'd go, oh, it's the Alfred way. Like, is that like evidence-based? Oh no, we've always done that way. You go, is that the best reason to do something? Is because we've always done it that way? Yeah.
Often not.
Yeah, I kind of like the evidence-based pathway. You know, there's actually good evidence for what we're doing. But there's a lot of commonality. Like, there's a lot of commonality across healthcare. And I think that the fact particularly that our specialists train in very siloed bubbles is a real problem to get that collaboration. And actually, one of the things they've introduced in Victoria is that all the JMOs now have to do rotations through mental health, because they've identified that there's just gross underskilling of our medical practitioners in mental health. So everyone has to rotate through mental health. It's a really great decision, except for the bit where they didn't resource that. You know, that's always the problem. And then there's a back impact, because that then decreases the medical student placements. So then you just underskill them in medicine instead. But you know, that's a great initiative. I mean, it used to be, and I'm not sure what happens with physician training and surgical training, they all had to do rotations in emergency.
I certainly did a lot of time in emergency as a basic physician trainee, but it does not happen now. And I tell you, the links that I made, I think, were invaluable. Bob Dunn and I spent a lot of time together, then we taught together. And yeah, I think that appreciation from the other perspective really breaks down that first cartoon you had of the two ships and the two tribes, breaks that down when you understand the other view.
I do remember one night shift sitting there, I think it was about 6 in the morning, and I had a neurosurgical patient who was so complicated, and the neurosurgical consultant it was fantastic, and had come in and talked to the family. And I had a patient who had a massive GI bleed, and the gastroenterology consultant came in and was also amazing and wonderful. And then the next patient that popped up on the screen, like the triage note said, patient thinks he's a vampire and wants to be staked in the heart so he doesn't hurt anyone. And they both just looked at me and they went, that's why I'm not doing emergency. But it was just like they had this moment of understanding that I've just, dealt with this complex neurosurgical patient, this GI bleeder who ended up just bizarrely had an acute leukemia, and that was the first diagnosis. So it was really complicated. And then that was the next thing. And then they sort of had this understanding, because they were talking to each other as well, as like, a day in ED is pretty diverse.
Good breath. Wow.
Yeah.
So from what you've told us, there is really good value to be gained from looking outside your own tribe. Does looking outside your own tribe help you elevate? I mean, I'm thinking back again to, I can't just tell them life's good and help them to come along, but I can't also just go point to other tribes and say, that tribe's doing it better, do more like that. That's not going to work either,
That's not going to work either, because then it's us versus them. Yeah, so that's about the leader of that group. So you as a leader of your tribe going to the leader of that, your other tribe, and saying, look, I've tried a bit of this. And I'm wondering maybe if, some of this could help. Maybe a bit of a service and org change might help. We've tried this, process. We developed X new process, and we tried this to try and, get our, team members along for the ride. What do you reckon? You guys are talking about introducing, why? Do you want some help with us? And we can help you with, what we did, and maybe help support you guys developing that, even though it's a different process. Because they've got that knowledge, they've got the tribe expertise, if you like. But you might have how do we do the education around that, and how do we do the change management? Because change management is all about people understanding the reason for change and actually feeling empowered as part of that change. You can't impose change.
No.
It's got to come from within.
Do you think tribalism changes based on external forces as well? So if you put more pressure on an organisation, you might, if we look at the collaboration that's occurred during COVID crisis, we've actually seen sort of a breakdown in some of those tribes a bit, and there's been much more collaboration, but equally it can actually increase pressure as well, and so everyone's become very defensive of their area as well. So how do you maintain the stability, I suppose? Ask you about that. Try when you get to a level that you're more comfortable with.
So if you're fighting to survive, so anyone that's watched any post-apocalyptic TV programs, you can actually see those very, very us versus them stages of tribalism, because it's about food, it's about water, it's about survival, okay? And people will be their worst when they're fighting for survival. And so actually pushing people to the brink where they feel like they're fighting for survival, you're going to actually break down your structure, aren't you? You're going to actually break down your structure because people huddle with what they're most familiar with and most comfortable with, which is their own tribe. Yep.
So you have to look after them.
You've got to look after them. Yeah.
I'm thinking as you're talking about the line, a manager's job is to stop the shit raining downhill on their people, if you will.
Yeah, absolutely. And it's really, really challenging in an organisation to walk that line between way too much pressure, because no one works well. You just basic educational theory. If you're cognitively overloaded, if you're emotionally overloaded, you cannot learn anything new. You just cannot. Your brain is full of that emotion and that overload. We use that principle in simulation. When we work with medical students, we just have someone in the room that can find the blood pressure cuff, find those things for them, and take that cognitive load off so they can do what they need to do. So really good leadership in an organisation takes load off its workers so they can do the work that they want to do. But that's hard when everyone is working at 110%.
Challenge. Yeah.
Yeah, but you can see how it will disintegrate very quickly if people feel they're fighting for survival, and they'll go into that stage 2, and sometimes even into stage 1 of tribalism. In those post-apocalyptic shows, they go into stage 1.
Do we have any other questions, any other comments? People online have been very quiet, unless I'm not seeing the chat. No, chat's all me. I've been typing away earlier.
Oh, okay, yeah.
Making sure they could see what the group was saying.
So this is the outcome we want. We want this healthy-looking guy who's happy, don't we? That's what we all want to unite to get. And maybe get some research and good evidence around what we're doing and be able to disseminate that evidence really well amongst all of our tribes so that everyone's aware of what can be done that makes things easier.
Yeah, telling the good news story about what collaboration looks like.
Yeah.
Yes.
Have you got any other suggestions for breaking down those barriers when you are in that stage 2? Because sometimes when people are in that stage 2, they're not always available, they're not ready to listen or to think about that because they're in that survival mode.
It's really tricky, and it is very much about the relationships then. So it's about the relationships between the leader and that person. They probably won't listen to the leader. So you need some champions in your team. You do. You need some people that are just that little bit further advanced in that process to really bring those other people with them. And they need to see a result of what they've done. So if you bring a team collaboratively together and they make suggestions and you come up with a plan, you can't just say, now we'll shelve it. You actually have to have some proper intent. Otherwise they'll just go, yeah, yes again. Not heard, not listened to.
I'm really thinking about this model that one of my colleagues showed me about. It was all around improving well-being in a team, and it's really pertinent at a time like this. And it was really all around getting the middle-level managers in a team together and asking them what they think would help well-being and letting them take some charge of that, and then actioning it and doing like a PDSA cycle. And I thought, oh, this is going to take a lot of effort. But I think it's the way to go. I think it's the way to go to help a broken, assailed team, because it follows a lot of these principles, and I'm thinking now I'm going to go back and look at it. Yeah.
May I have a...
Yeah, absolutely. I'll send you the article because it steps it out, and I think it might be something we can all do to heal some of the hurt that's happened with the pressure of COVID and workload.
And you can imagine where Victoria is at the moment.
Yeah.
So Victoria's gone to the extreme. So we are so desperately short of nursing staff that the new graduates are like, yeah, I can get any job I want. Literally, that's where we're at. They can get any job they want. And so they're actually being a little bit demanding about it. And good on them, you know, demand those better conditions and so on. But yeah, it's you know, like Epworth at one stage, I think they have 40 operating theatres, so it's pretty substantial. And they were running 13 theatres. Because the theatre staff were a little bit better than some of the other staff, the nursing staff. They do tend to be quite passionate about what they're doing. But a lot of our ward staff left, and rehab nurses, I don't know why, they all left. They were doing a lot of the COVID rehab though, but that was, you know, pretty intense. But yeah, just mass exodus, and not just Epworth, that's across Victoria.
Yeah.
And they got burnt out. You know, they were always working shifts where they were understaffed, and they just got sick of it. And you know, fair enough.
Well, we are out of time, and look, I'd like to say thanks very much. I think this is a really important concept to consider at this stage. As I said earlier, it really is a way, a framework, a great sort of reflective piece that we can do to think about how we move forward at this stage. So thank you, Christine.
Thank you.
And thanks to everyone online. There has been some chat there saying, sorry to leave, great presentation, listening hard as this is interesting. So, yeah.
Thank you.
And I did get a text to say this is very timely and just what our organisation needs. Great choice of Nimmo.